The first one is that you can look at liver death rates in all of the different, these are the different countries in the WHO European region. And you can essentially, split them into 4 or 5 main categories. There are some countries which have always had a very, very low level of liver mortality. Netherlands would be one, or Sweden. There are some countries which used to have a very high level of liver mortality, and that liver mortality rate has dropped considerably over the last few decades. And this would include the Mediterranean countries, France, Spain, Italy. You have other countries which have very, very high levels of liver mortality, and in many cases, this is still increasing. And this is mostly the Eastern European countries. And then you have countries like the UK, which used to have a very, very low level of liver mortality, and that liver mortality has gone up. And in terms of the UK, it's gone up between 4 and 5 times since 1970. So the take-home message from this is firstly that there are very, very different situations in different EU member states and different European countries. But perhaps more importantly, liver death rates can change dramatically within a relatively short period of time. And it's possible for policy to change those death rates. In other words, the majority of liver diseases, death is preventable. And we could really address the very high and unacceptable level of liver mortality in Europe with policy change. And I just want to very quickly give you an example of that. This is just showing you the change in alcohol duty in the UK since 1980. The drinks industry have been extremely competent in terms of lobbying with the government, and what they've managed to do is achieve year-on-year duty decreases, either through duty freezes or duty cuts, such that the overall rate of alcohol duty, which is the blue line, is now half of what it was. And we can show that that has caused this increase, the black line here, in liver death rates. There's a direct relationship between the price that you pay for alcohol and the number of deaths from alcohol, the death rate from alcohol. And in terms of public policy, increasing the price of alcohol is not only the most effective, it's also the most cost-effective policy option. It's exactly the same as tobacco. The best way to reduce smoking is to put up the price of cigarettes through taxation. And that's how we've had massive improvements in levels of smoking in Western Europe. The second most effective thing you can do, incidentally, is to control marketing to children or prevent marketing to children. The cost of these tax cuts in the UK is around about the same cost as the whole of the UK nuclear deterrent, just to put that in perspective. This is a huge amount of money that has been given away to the drinks industry. And that's the reason that we're in the situation we are in terms of death rates. Now, I want to go on and talk about the link between obesity and alcohol, and then I'm going to hand over to Shira. Currently, around about 23% of the population of Europe have a BMI greater than 30. So they're termed obese, and this figure is rising in every country every year. And the important thing as far as the liver is concerned is that there's a risk of liver disease from obesity, non-alcoholic fatty liver disease, which is a terrible name, and alcohol-related fatty liver disease, both of which lead to liver scarring, and they can then result in cirrhosis and hepatocellular carcinoma. If you're overweight or obese, the effect of alcohol is amplified. It's not added, it's amplified. And the liver toxicity of alcohol doubles. So in effect, if you're drinking 2 bottles of wine a week, for example, that turns into 4 bottles of wine a week as far as your liver's concerned, if your BMI is greater than 30. Similarly, 2 bottles of beer turns into 4 bottles of beer, and 2 bottles of spirits turns into 4 bottles of spirits. And this combination of overweight and alcohol is extremely important, particularly in Europe. The situation in the United States is different. They have a a large population of people who hardly drink at all, and they have a lot of people who are very, very overweight. And so they have a lot of obesity-mediated liver disease. In Europe, it's different. Very few people don't drink at all. The majority of people drink a bit, and quite a lot of people drink a bit too much and are also overweight. And what we're looking at in terms of the patterns of liver disease in these countries is a combination of alcohol and obesity. Probably around about 30% of drinkers are also overweight. And this is my final slide, and it's just pointing out to you where we could be, because in Mexico, only 24% of the population have a healthy weight, and they have an obesity rate of 36%. So this is the, they're the most overweight country, certainly in the Americas. There's a few places in the world that beat them. Interestingly, 70% of their dietary sugar comes from soft drinks, and obesity rose in Mexico as a result of the sort of transmission of eating cultures from north of the border. And it's just pointing out to you that the liver mortality rate in Mexico is as high as Hungary, and Hungary is the highest in Europe. And this is, again, is a result of a combination of alcohol and obesity. And this is where we're going in European terms, unless we can do something to curb the increase in obesity, and unless we can do something serious in terms of alcohol policy. And the message for alcohol policy couldn't be simpler. We just need to put up alcohol taxation or adopt an effective minimum unit price. Shira, can I hand over to you now?
Yes, thank you, Nick. It was a great opening to my talk. I'll just share my slide. Here it is.
Before you start, Shira, if I could just ask anybody if they've got questions or comments to type them in the chat function so that we can look at them all together.
Okay. Can you see my slides?
Yep.
Okay, thank you. So Nick and I are actually sharing the talk about alcoholic liver disease and non-alcoholic liver disease. And in fact, we believe that the separation between the two liver etiologies is arbitrary, where in fact many people who are obese also drink, and many people who overdrink are also obese. It can be between 30 to 50% of the people who share both etiologies altogether. So we actually wanted to emphasize in this policy statement kind of a new concept that there is no need to separate the two diseases. And if we look at them together, we might understand better the amount of liver damage that can be caused by both etiologies, and the similar policy measures that we can do that can help us beat these both leading etiologies of liver disease in Europe. So actually, non-alcoholic fatty liver disease, it is now suggested to call it MAFLD, metabolic associated liver disease, because it's not just a disease defined by the exclusion of alcohol intake. It is actually a metabolic disease, basically strongly related with obesity, unhealthy lifestyle, is unhealthy diet, and lack of physical activity. So we try to present today, Nick and I, together this new concept. And Nick was talking about alcoholic liver disease. I would like to focus a bit on non-alcoholic fatty liver disease or metabolic liver disease. And so actually fatty liver disease, metabolic liver disease is the most prevalent liver disease worldwide, and especially in Europe, with about 25% prevalence in the general population. And more than half of the patients are obese. And you can see on the left, you can see that there is a correlation in different countries between the level of obesity and the prevalence of liver disease. The greater is the obesity, the greater is the prevalence of metabolic liver disease. And there are several levels of synergism between alcoholic and non-alcoholic and so-called non-alcoholic liver disease. And so we can see in this study, for example, as Nick mentioned, that they have synergism in causing liver damage. In this specific example, we can see that people who are obese, who have greater waist to hip ratio, meaning a greater abdominal obesity, and they drink alcohol, the risk they have to develop severe liver disease is much higher than the risk of people with normal weight. And even within the normal drinking limits, even within the normal 20 grams of alcohol per day, you can see that people who have obesity or abdominal obesity have a much greater increase in both men and women to develop severe liver disease, even within normal alcohol consumption. And when we look at liver disease mortality, we can see that people who are overweight or obese have almost 19-fold increased risk to have liver disease mortality if they also consume alcohol. And even within the regular consumption of alcohol of up to 14 units per week, they still have 5-fold increased risk of having liver disease mortality. This is as compared to normal weight patients, as you can see in the green, who drink a lot of alcohol, they only have 3-fold increased risk to have liver disease mortality. So there is absolutely an additive effect of alcohol and obesity in terms of liver damage. And importantly, this is also true for hepatocellular carcinoma, for liver cancer, where the combination of obesity and drinking leads to 7-fold increased risk of having liver cancer as compared to a lower risk among those who are not obese. So the second level of synergism is behavioral. We know that bad habits tend to stick together: obesity, bad diet, alcohol drinking, and also smoking. And if we talk about diet, we need to talk about also dietary composition, not just obesity. Nowadays, we know that the consumption of ultra-processed food is very common. In fact, they comprise about 50 to 60% of the total daily energy intake in several high-income countries. So this is a major contributor to the calories in Europe. And here you can see examples of unprocessed or minimally processed food typical to the Mediterranean diet as compared to ultra-processed food products, which are basically a major source of sugar, soft drinks, as Nick mentioned, and saturated fat. And indeed, sugar has been demonstrated in many studies to be related with liver damage, especially with metabolic liver disease. And in this example, we can see that children with liver biopsy who consume a lot of sugar have 60% increased risk to have advanced metabolic disease. It's called NASH. So this is really significant. And there is no wondering that pediatric associations recommend to reduce.
Shira, we cannot hear you anymore.
Yeah, we lost your voice, Shira.
I'm sorry, can you hear me now?
Now we can.
No, Shira, please, can you hear me?
Yes.
You're
Stop.
muting.
Can you hear me now?
Yes, it's okay.
I think you muted everybody. So
sorry for that. It was me. I agree. Sorry for that. Yeah.
Yes, it's your fault, definitely.
It's my fault.
So where did you lose me? In this slide or the one before?
This one.
In this one, just for
In
a
this
second.
one.
Yes.
So emphasizing the strong effect of sugar, not only on fatty liver, but also on causing advanced liver disease, it's not a surprise that pediatric associations strongly recommend to reduce sugar intake in the entire population, and especially among children. And this high consumption of sugar disproportionately affects minority and low-income communities. So it's really important to put a lot of emphasis on sugar reduction in terms of liver health. Smoking is really an important risk factor. Sometimes we tend to forget about smoking, but it is also related with liver damage. And we can see in this very large cohort that the more people smoke, the more they have NAFLD with advanced fibrosis. So it's also related with steatosis, but also with fibrosis. And importantly, smoking has been repeatedly demonstrated to be related with liver cancer as an independent risk factor and with synergism with alcohol consumption. So both alone and both with the alcohol consumption, smoking is other significant etiologic factor in liver disease. And therefore, the EASL in this policy statements recommends that both health providers and patients need to be educated and aware of the frequent coexistence of both etiologies of liver disease. And they also should gain improved knowledge about relevant behaviors and treatment pathways. So both caregivers and both patients should be aware of the coexistence and the treatment options that should be combined many times. And interestingly, this is my last slide, when we look at public health policies to beat alcohol, obesity, and smoking, we can see that the three of them share very similar policies. They focus on taxation, they focus on marketing regulation like bans on advertising, and they focus on behavioral intervention, which have been shown to be effective. So if we combine efforts in policy measures, we might have even better results than to treat each one of them alone. Thank you.